Relative to Congress and the way we've dealt with the reimbursement issue and the cost for reimbursing physicians over the year with respect to Medicare, how inconvenient is it and how detrimental to doctors and others who depend upon this, and the patients as well, when year after year we have a tendency, and the cuts are out there reflected in either the president's budget or perhaps our budget, but by the end of the year the fix comes very late, and so people don't know what it's going to be, and for planning purposes and everything else, I'm sure that there's some negative impact. Could you discuss that and what kind of problem that is?
Sure. You're absolutely right, Congressman, that it probably is very disruptive for physicians, because if they want to make plans in terms of their practice, whether it's to buy a new piece of equipment or invest in, say, an electronic health record or something like that, the fact that they don't have predictability and stability in their payment system to know how they would amortize that out over the years in the future does create real disruption that's out there. Also, I think it's disruptive in the area in terms of Medicare beneficiaries to know whether a physician might take someone who now becomes age 65 and want to take on additional Medicare beneficiaries as patients, or whether a physician may want to participate in the Medicare program that's out there. So I think for any business person in this country, regardless of whether it's healthcare or anything else, they need predictability and stability. And under the current physician fee schedule and the payment system we have now, they're not getting that.
Right. And we've unfortunately seen that the fact that this delay that's in the system occurs year after year, whether it was in Republican control or Democratic control now, it seems to be not really a political thing. It's just the way it works up here in Congress, or doesn't work. And I think really Congress needs to get its act together so people can be a little more, it can depend upon things to come and be able to plan in advance. What can we do about rewarding inefficiency and their rewarding efficiency, and therefore encouraging more of it?
One of the best ways that we've really looked at is that we really need to measure in this area, and we need to really get this set of quality measures as well as resource use measures that we can really kind of look at efficiency. If you look at the Medicare payment system now, at least for physicians, we pay on volume, we don't pay for value, and we don't really know what kind of outcomes that we're getting as a result of that. And that's why we see this great variation in terms of care across the country, and in a lot of cases great inefficiency in the system that's out there. So I think one area is the development of measures, and the physician community, I think particularly led by the American Medical Association's consortium, is doing a very good job of developing new quality measures, thinking about efficiency measures as we go forward. But it's more than just measuring it. It's really then do you attach payment to it to really kind of drive the incentive as we go forward. And I think that's the next hill we all have to cross. But I think we're doing a very good job of building the infrastructure to get the measures in place. The next question is then how do we deploy those measures? And ultimately, do we make those publicly available? Because that's part of the accountability as well as transparency as part of this too.
Thank you. What was the participation rate in the Physician Quality Reporting Initiative in 2007, and what percentage of participation was from office-based small practices? In other words, 6 physicians or less.
It's a good question. Under PQRI, which began in July of 2007, our current indication is about 16 to 17% of physicians participated in that first 6-month launch of the program. Some people have looked at that and said, boy, that's not a very high number, but a couple observations about that are worth noting. One is, when it was authorized, it was only authorized for 6 months. So if you're a physician and you're trying to decide whether to train staff how to operate in this new program or do you make the investment, if it's only for 6 months, you might want to think twice about that. So I think 16% with that level of uncertainty was pretty good. The second thing is physicians, when it comes to these kind of programs, sometimes are slow adopters to the program. We have the participating physician program. A physician can be either participating or non-participating in the Medicare program, and that has a differentiation in payment. When that first started, physician participation was about 25%, and then over the next decade it grew to about 95%. So I think the early start of this program looks good. In terms of the breakdown of the smaller physician offices, I don't know if we have that numbers broken down that way. We have it more by specialties, whether it was ophthalmologists or others. But in terms of practice size, anecdotally, the information I hear from our medical officers in CMS is that it looked like physicians across the spectrum, both small and large, participated. And that seems to make sense because when you look at physician practices overall, about 50% are physicians in practices of 2 or 3 or less. So I would think we would have had good representation by smaller offices as a result.
Thank you. Madam Chair, I yield back.